A 69-year-old lady with underlying hypertension, bilateral CA breast with surgery performed in 2013, currently on tamoxifen, and also a known thymoma with right fat thymectomy performed in 2006 with post-op radiotherapy. Had an incidental finding of a pancreatic cystic lesion in the CT in 2010. And over the past 8 years, it showed interval increase in size, with the latest CT in 2018 showing a 2.9 by 3.8 centimeter cystic lesion. And this slide shows the difference in the sizes of the pancreatic lesion. And today we'll be performing an endoscopic ultrasound with fine needle aspiration and also confocal endomicroscopy.
I'm Uzma Siddiqui, and then I have Professor Seoul with me in the room. His first suggestion to me for this case was to sit down for the EUS, but I'm going to prefer to stand. Just a couple things in the presentation whenever you're thinking about the workup and differential for pancreatic cysts. Obviously, we're trying to distinguish mucinous from non-mucinous lesions. And first thing, the patient's age, 69 years old, so that could fit into an IPMN category. She's female. The location of the cyst is in the head region, and she's asymptomatic. This was an incidental cyst that's been growing in size. So perhaps this could be an IPMN lesion given all those things. And then now we'll proceed to the EUS. Yeah. Just a few basic anatomy points that we'll show.
Are you looking at EUS now?
Yes.
Yes, okay.
We have an Olympus UCT 260 series. In the US, we use the 180 series. And then we also are going to, we're using a linear scope. So the scope right now is in the proximal stomach. You can see the celiac. We might have some assistance coming off the aorta. And then it's going to split into the hepatic and splenic arteries. And it's going to lead you right into the pancreas, body and tail. Now, there was a suggestion of some pancreatic duct prominence on the CT scan, because we always also want to comment on whether the pancreatic duct is dilated or not. We measured the PD to be about 1.4 millimeters in the body, so it did not appear dilated. And then you're already starting to see the cystic lesion here from the proximal stomach. And in many patients, especially thin ones, you can view the head region from the stomach area. But we'll go down to the head from here and then get a better view. So now we're going to move the scope into the duodenal bulb. You're seeing the gallbladder briefly as we enter through the pylorus. And now, once you pop right into the duodenal bulb, here again you see our cystic lesion. We measured it at about, I think, 3.3 centimeters. It looks multi-lobulated. There are thin septations. The other thing we always comment on EUS, if there's any mural nodules or any eccentric wall thickening, none of which we see on this lesion. And then we also see the bile duct just going superiorly, and then we see the portal vein adjacent to the cyst. And then the one other thing we always want to comment on is, do we see any communication with the pancreatic duct? And if we go into the D2 position and start pulling back, you're going to see the uncinate parenchyma, and then you're going to start seeing the pancreas duct right there. And we do see pancreatic duct communication with the cystic lesion.
Yeah.
So now you could argue...
This is cystic lesion, this is pancreatic duct. This is beautiful demonstration of communication of pancreatic duct and the cyst. Yeah.
So we probably both agree that this is an IPMN lesion.
Yes.
It has been growing in size over this past, I guess, 8 years. And so it's not very rapid growth, but it is growing. And there's no other worrisome sonographic features at this point. So I guess for our panel, the discussion could be, we have a couple ideas of some advanced imaging modalities we can do. But the question is always, do we really need it? Since we already have an idea. We'll probably will today, but
But that's not definitive diagnosis. If we have more data, then we can get more accurate diagnosis.
and I agree, especially if this is an enlarging lesion, you were going to consider surgical resection.
Right.
It would be a Whipple. It would be nice to get
That's,
more confirmatory testing.
Right.
So what do you think about perhaps confocal?
In this case, if we add confocal endomicroscopy, we can get more data supporting our speculation, IPMN. And in this case, the lesion was detected in 2010. And at that time, it was just 2 cm. And for 8 years, the size became 3.8 cm. So during 8-year period, it showed slow growth and slow progression.
Yeah.
This is one thing we need to think about whenever we are looking at the cystic lesion of the pancreas, especially in the head lesion. I think many people think about surgical resection is the only cure, but this patient can live without surgery with high quality of life.
I think also we can, I mean, it's maybe a lengthy talk, but there's so many pancreas cyst guidelines.
Right.
And in the early stages with the original Sendai guidelines, you know, it was more if a cyst was over 3 centimeters, that would be an indication for surgery.
Yeah.
But as the guidelines have evolved, size by itself is not a criteria for surgery, and we're
Yeah.
looking for rapid growth, mural nodules, PD dilation, more worrisome findings.
Yes, Sendai and Fukuoka guidelines are focused on IPMN and the mucinous lesion, but we are looking at also other lesions too. Yes.
I don't know if we can focus in on my hands now. We have.
We are trying to show the confocal endomicroscope. It's already inserted inside a 19-gauge needle. Can you see the tip of?
If you can zoom in on the tip. So this probe is 0.85 millimeters, and it goes through a 19-gauge needle. We preload it into the needle, and then it should just extend a few millimeters back because it can easily get broken. And the whole confocal system is based on giving the patient a contrast agent in the IV. We gave the patient IV fluorescein, and then it's taken up by the cells in the lining of the pancreatic cyst. And then we're going to shine a low-powered laser with our probe once we're inside the cyst. And then the system allows for images to be collected through a pinhole aperture, and that allows any scattered angles to be dismissed from a really high focused image that's about 1,000 times magnification, and you have about 3.5 microns resolution. Oh, yeah.
Uzma, is a serous cyst part of your differential here?
It could be, yes, you're right. But I mean, this doesn't look like a typical microcystic honeycomb lesion, but there are macrocystic variants. The fact that I saw very clearly pancreatic duct communication with the cyst makes me think that serous cyst is less likely. But after we do some imaging, I usually do send my fluid for CEA, amylase. I mean, they're not perfect tests, but if the CEA was less than 5, then perhaps we would entertain serous cyst adenoma on the differential as well. All right. So now we're going to try to puncture. Sometimes it can be a little difficult because your needle tip may not be as sharp with the probe in it. Oh, and then I always do Doppler before I do my FNA to try to avoid any big vessels. We're using a 19-gauge Cook Ultra needle. I don't like to use core needles to go through cyst walls. I always have a concern about shearing the wall in pancreatitis, but I usually tend to use a regular needle.
I also use just a regular 19-gauge FNA needle for cyst. Yeah. And this is duodenal position, and the scope tip is angled a little bit, and this is 19-gauge needle, steeper needle, so there can be some resistance.
We'll try to get it in.
Yeah. Okay.
Okay.
Now we are inside the cyst.
So the issue here, whenever you're doing confocal imaging in a pancreatic cyst, as everyone knows, histologically, these cysts have really varied epithelium if you were to resect the entire specimen. So depending on where your probe hits the cyst wall, you're kind of limited in terms of what views you're going to get, which is why, I mean, our group has been the lead author on a few studies related to confocal in the pancreas, especially the initial study in the pancreas we published in 2011. And we have identified a few criteria for IPMN lesions in particular. We could switch to the
Confocal image. Yes.
We found these papillary projections. If you see them, you have 100% specificity for an intestinal type IPMN. But your sensitivity is only 50% because a lot depends on me being able to actually get the right part of the wall that may show these lesions. And I don't know why this is having that black line. So this confocal captures images at about 12 frames per second. You're seeing, oh, actually, you're seeing
That
some blood
area,
vessels
yeah.
there.
Uh,
Let me see. Would you have a trackball to roll it back? Oh, perfect.
Yes.
Yes.
Yes. That
So
area.
right there, you're seeing some blood vessels. Although it's interesting, Moen, you brought up serous cyst adenoma because there is an imaging criteria, a superficial vascular network that Napoleon described in endoscopy in 2015 for serous cyst adenomas. But you can also sometimes just see some vascularity on the cyst wall. But it's a little bit of hit or miss, for sure, with confocal. And I'll be honest, we probably don't use it as much as we did in the early stages. But papillary projections are very specific if I can find them. So I try to just scan the wall a little bit. If possible, we're just seeing some normal vasculature. Actually, right there, you can see some blood vessels. Can you put the trackball here?
Trackball.
I'm not seeing any papillary projections yet.
Uh,
We'll try moving around a little bit. The one thing also in our 2 studies we published, we've noticed a little bit higher rate of pancreatitis, maybe 2 to 3%, and sometimes you wonder if that's because you spend a lot of time inside the cyst interrogating the wall.
do you select certain points by EUSPU?
If there's any nodularity, I would try
yeah.
to target that. I
But
try to target the cyst wall. We'll try to target a little bit here.
But in this case, we cannot find any mural nodule.
No,
so
there's nothing
yeah.
specific that I would target at this point.
Yeah.
Do you guys ever aspirate the cyst before you do
But we-
endomicroscopy to be able to approach the wall better?
I'm sorry, what did you say?
Do you, if you have a very large cyst, do you aspirate some fluid?
Yes. No, sometimes I do,
to be
but
able to approach the wall?
But in this particular case, I was able to get to the very deep back wall, and now I just pulled back. So I didn't really have any trouble getting to the wall. But that is something that we do if it's larger. In this case, I think it's just, again, it's a matter of trying to find any actual intestinal epithelium. But we'll try just for a few more seconds, and then if we cannot find anything, we have one more tool to try to get a histologic diagnosis. We were discussing using microforceps.
If this does not give enough evidence, then we can add one more. We are going to use Morey forceps to do the cyst wall biopsy, and we want to check the lining epithelium.
And then at the end, we'll aspirate all the fluid out. I mentioned CEA amylase cytology I usually send, although everyone knows probably the cytologic yield is pretty low, less than 50%.
Less than 20%, I guess,
20%,
from my
yes.
experience.
I
If
would
the
say less
cyst
than
has a large mass, then the yield is high, but it's already
Correct.
obvious. But
Yes.
if the cyst is ambiguous lesion, indeterminate lesion, oligolocular, then the cystic fluid analysis does not give generally the cytologic yield. So quite a disappointing cytology.
Now, the couple studies this year that I think we'll switch out. I'm not really seeing too much
Not yet.
with this.
Probably.
So we'll come out with the confocal probe, and we'll go with the microforceps.
By adding confocal, at least we did not see any definitive papillary projections.
Correct. It is. It's going to be a little bit.
So
I was going to say with the microforceps, the couple studies that came out this year, they said there was one from University of Colorado and another multi-center study. I think the lead author was Dennis Yang from UVA in the States. But they claim that their yield for for diagnosis was higher than cytology.
Yeah.
I think they got 50% versus maybe 8 or 9% on cytology. So I don't know if you can close up on the forceps now. Do we have a gauze? Okay.
We are going to use this moray forceps. Can you see the tip? Zoom in the forceps.
Can you open
Yes.
and close them? So
Please open it. Yes.
it's only
Yes.
4.3
Millimeter. Yes.
And
That's pretty big size. 4.3 millimeter. The alligator, if you open it, and it goes into 19 gauge needle.
Oh, hold this 1 second. I'm going to puncture. Okay. So our confocal probe got a little stuck coming out, so we did pull our needle out. I try not to re-stick these lesions as much as possible, and then I do try to aspirate all the fluid out. We did give the patient pre-procedure ciprofloxacin. I don't tend to give antibiotics after if I can aspirate the entire lesion.
Yeah. About 15 years ago, when I tried to do differential diagnosis of pancreatic cyst, at that time just the EUS B-mode image was available. And the differential diagnosis, many doctors and the sonographers insisted that the accuracy of EUS, B-mode image EUS is quite accurate and sensitive, but when I did analysis on my patient, it was quite disappointing. It was for differential diagnosis of pseudocysts from others, it's good. But when it goes to mucinous or serous or IPMN, the yield was not very good. But nowadays we have, as you see here, confocal endomicroscopy and also moray forceps intracyst cyst wall biopsy. So we have many other armamentarium to get the better differential diagnosis here.
So you can see, hopefully I'll try to zoom up, you can see the forceps coming out of the needle tip there.
Yeah.
And they're open and then close. And usually you can kind of feel a little bit of tissue.
Yeah.
Now, in the few studies that have been published, they have mentioned complications of pancreatitis, intracystic bleeding, and I think there was one case of infection. So around 5% rate of complications.
Is there any risk of cyst wall rupture and the cystic fluid leakage?
They have not reported it,
Not
but that's
yet.
something perhaps to consider as well.
So do you have a sampling protocol? How many you take? And obviously you do not have somewhere that you are targeting your biopsy forceps.
Correct. In this one, I'm just targeting the wall itself. But again, there could be sampling error depending on the actual histology of the cyst lining. I usually do about 3 passes, but in our center, we just started using these forceps, so we have not developed an official protocol yet.
If there is any definitive target, such as mural nodule or wall thickening, septal thickening, then we can target that area. But in this case, we don't have clear targets, so we are just targeting the wall of cyst. I agree with. So I call this kind of lesion, if there is no clear communication with the MPD and the cyst, then this category will fall into the oligocystic cystic tumor. Maybe the differential diagnosis is not easy.
But with no other worrisome findings at this point, she's
Yes.
asymptomatic. Probably you would opt for ongoing surveillance.
Size more than 3.8 millimeter, depending on more than 3 millimeter is one of
Open.
3cm is one of the worrisome feature by
But not by
Fukuoka
itself.
guideline.
Not by itself.
Yeah, right.
Okay, thank you. We'll move to another room and we'll let you finish the procedure. Thank you very much. Nice case.
Thank you.
So after we made 2 passes actually with the Mori forceps, and after the second one, I noticed there was some active intracystic bleeding. And if you can see the EUS image now, the cyst has completely filled up with blood. It stopped though now that it refilled the collection, but
Yeah. So
we
during
wanted to demonstrate that issue.
this is one. I want to give some message to other endosonographers because we are dealing with a lot of FNA and puncturing the solid lesion or cystic lesion. During US, after second biopsy, we saw some echogenic jet going inside, and it looks like it's arterial bleeding, and it looks very serious. But if you wait, most of the times, the bleeding spontaneously stops, like this case. But we can see some echogenic debris because of bleeding inside the cystic lesion here. Most of this type of bleeding will stop spontaneously, but I think better to give some antibiotics as a precautionary measure.
No, that's what we were discussing, that they are going to observe the patient afterwards. I would give antibiotics. And obviously we continued to watch this until the bleeding did stop.
Yes.
And her vitals remain stable throughout. So hopefully she won't have any issues, but this has been described in the initial use of this forceps, so now you've seen it.
We would be happy if there is any comment or question
And I guess the one thing on our case we did not summarize at the very end. So this lesion is over 3 centimeters. It's grown slowly over the last 8 years. So then the question is surgery versus observation, but we didn't say or mention, but the patient should be seen by a pancreatic surgeon probably and have a discussion depending on her wishes, her other comorbidities.
And I think we need to, before selecting certain type of therapy, we need to explain the benefit and the disadvantage of that therapy. Surgical resection, yes, that's definitely definite way of treating cystic lesion, but it
not
is
always needed.
But it creates another issues, pancreatic function loss, and also sometimes diabetes, and also if you make any anastomosis between bile duct and jejunum, and also pancreatic duct and jejunum, later it can create some stricture and cholangitis or pancreatitis. That aspect also need to be explained.
But the discussion should be had, multidisciplinary discussion.
Right.
Uzma, couple of points. This patient is 68, right?
Right.
69, right.
Yeah,
and has
so
breast cancer
so
history.
they're still healthy now at 68. You know, 5 years down the road, they're less healthy. So I think a serious discussion with a surgeon about a Whipple at this time is seems to me a logical consideration. Patient is not going to get younger or healthier. We've seen this bleeding with, we had 2 cases of bleeding with Moray forceps with serous cysts, because these cysts are more vascular. So you see them, but as you guys saw here, usually the bleeding tamponades itself, but it's a nidus for infection. So, and also patients can have pain afterwards, obviously.
Yeah, we did discuss that with the team already, that she probably will wake up with some discomfort. Any other questions?
Okay, thank you.
Thank you.
Nice demonstration.
Okay, thank you. Thank you very much.